Okay, our next speaker is Jock Rollins, who is the Senior Policy Analyst for the National Association of Medicaid Directors, where he is responsible for the association's policy work, including analysis of legislation and regulations impacting Medicaid programs. Jock received a Master's of Public Health from George Washington University.
All right, good afternoon, everyone. It's great to see so many folks interested in CHIP and CHIP reauthorization. So I wanted to provide a little bit of information about NAMD, who we are and what we do. NAMD is a bipartisan and nonprofit association that represents 56 Medicaid programs, so that's the 50 states, the District of Columbia, and the 5 territories. Our members are the Medicaid directors that oversee the Medicaid programs in each of those jurisdictions. And we are essentially the trade association for the Medicaid directors. We serve to develop and promote Medicaid leadership, both at the Medicaid director level and throughout the agency and their mid-level staff. And we also serve as the disseminator of federal activity that's going to impact the Medicaid program, whether that's from here in Congress or from the administration. And we distill the consensus position of the Medicaid directors and communicate that back to policymakers and other key stakeholders. So I wanted to just provide a little bit of background information on the Medicaid program writ large before I get to the interactions between Medicaid and CHIP, just to make sure that everybody is kind of familiar with where we're coming from and appreciates how CHIP and Medicaid interface. So Medicaid is a joint federal-state program. The states are co-financers of the Medicaid program, and they administer the programs at the state level. They're able to have significant leeway in terms of benefit design and covered populations, and CMS, or the Centers for Medicare and Medicaid Services, provides the federal regulatory oversight. Medicaid covers approximately 72 million individuals right now and provides a wide array of services that no other payer really provides. Some examples of that include Medicaid as the primary payer of long-term services and supports for the nation. This is particularly prevalent in terms of services that are provided in the community. We call them home and community-based services. Medicaid also interfaces with folks called the dually eligible, who receive both Medicare and Medicaid services, one of the frailest, most clinically complex, and costliest populations in the nation. Medicaid, as we've heard, is a key payer of behavioral health services, as Medicaid programs are frontline in addressing the opioid epidemic that we've been grappling with as a nation for the past several years. And another statistic is that Medicaid covers over half of the births in this country today. So shifting now to the intersection between Medicaid and CHIP is that Medicaid and CHIP function a little bit differently, although writ large they are broadly similar. First, CHIP has enjoyed some strong bipartisan support since it was established in 1997 and is a key tool for providing coverage and access to care for pregnant women, families, and children. As we've heard, CHIP is a key tool for providing early intervention, which is a great way for improving long-term health outcomes. CHIP is one of the tools in the state's toolbox for addressing what we call social determinants of health, so things that we don't necessarily connect initially with health care, but have a significant impact on health outcomes, such as providing stable housing and access to food services and things like that. One example of the creative uses that states have been able to put CHIP to actually comes from Michigan. I think we probably all recall the lead abatement crisis in Flint, Michigan. Well, the Medicaid director in Michigan was able to use a portion of that state's CHIP funding to finance lead abatement services in the community of Flint, and now it's being expanded to other parts of the state. So that's an example of the type of flexibility and creativity that CHIP provides for states to address key social determinants of health. So a little bit from the administrative aspect, states can administer CHIP either as a standalone program, sort of separate from Medicaid. CHIP can be an extension of the Medicaid program, a targeted expansion of Medicaid financed with CHIP dollars, or there can be a combination of both. Most states use a combination approach. Very few states have a standalone CHIP program. The vast majority have a combination standalone CHIP program and a Medicaid expansion program. So states are able to set CHIP income eligibility levels at a wide variety of levels. Usually it's higher than what is covered under Medicaid for children or families. And some states have CHIP eligibility levels at or above 300% of the federal poverty level, but most fall between 150 to 250%. State-specific breakdowns are actually provided as of fiscal year 2016 from the Medicaid and CHIP Payment and Access Commission, MACPAC. It's a great resource if you're not familiar with it. I would highly recommend looking at their analyses. A little more on terms of data points from MACPAC around CHIP. Between Medicaid and CHIP, nearly 46 million children are covered, and of that, 9 million are covered through CHIP. That's about 5.2 million in a Medicaid expansion option, and about 3.7 million in a standalone CHIP program. So I'm going to get into the policy because that's what I do, so I'd be remiss if I didn't dive into that. So the CHIP program at the federal level sets state-specific allotments that states essentially use their Medicaid match, or the kind of state dollars that are used to draw down federal dollars from that CHIP allotment. Now, when the Affordable Care Act was passed, the CHIP match, in terms of the amount that the federal government gave to states, was enhanced by 23 percentage points above what the state's Medicaid match is. So what that means in practical terms is that under current law, the majority of CHIP financing comes from the federal government. And in some cases, for states that had particularly high federal match which is based on the amount of federal poverty in the state, some states have their CHIP allotments entirely financed by the federal government as it stands right now. So what does that mean for reauthorization and appropriations for CHIP? As I'm sure we're all aware, current CHIP allotments and CHIP funding expires at the end of this fiscal year, the end of the month, September 30th. But that doesn't align with the budgetary and operational decisions that states have made already. So September 30th sounds like a hard and fast deadline, and in many senses it is from the state operational perspective, but states can continue to spend or draw down their CHIP allotments past that date. Additionally, the Centers for Medicare and Medicaid Services has the ability to reallocate unspent CHIP allotments across the states, which has led to a MACPAC analysis suggesting that states won't be exhausting their CHIP allotments until at the earliest December. So that might give you a sense that there's some wiggle room here, there's some time to delay, you can negotiate on some of the aspects of CHIP policy and maybe make a decision in December. But from the state perspective, that is not the case. So examples of what I mean by that. Every state legislature has already set state general fund allotments for CHIP, for Medicaid, and that's kind of set in stone. The majority of states, I want to say 36, maybe more, assumed that CHIP's current arrangements would, as they stand under current law, with the 23 percentage point enhancement, would remain in place. Were that to change, states would have to reconvene their legislatures, find additional state dollars for states that have entirely federally funded CHIP programs. That would be a tremendous challenge. So our ask really is that Congress act sooner rather than later, and ideally before September 30th, to provide states with some operational certainty around what the future of CHIP is and what it's going to look like. The closer that states get to exhausting some of their CHIP allotments, and the more that state actual beneficiaries, children and families on the ground, are going to feel those effects. And the reason is this. States often have, in either state statute or regulation, a requirement to notify beneficiaries that the coverage you're receiving under CHIP may be changing. It might go away. We might be altering the benefits. You might need to be considering options for coverage elsewhere, whether that's in Medicaid or the exchanges. And in some cases, folks might end up being uninsured. Obviously, that's tremendously disruptive for a beneficiary, and it's a situation that could be avoided if Congress were to act in a timely enough manner. We don't want to end up in a situation where states send out these types of notices, but we all know that Congress will end up refunding CHIP. So states have already in the planning stages for the future of CHIP. Some states have kind of gamed out a work plan which suggests that they would need at least 6 months and ideally a year to wind down CHIP should that be necessary. None of us really think that will be necessary, but it's the kind of lead time that states need to make these operational programmatic decisions and minimize disruption for beneficiaries. So states need commitment from Congress and commitment from the federal government that CHIP will be continuing, and at minimum for at least 2 years, ideally 5 years, and for at least 2 years, the 23% enhancement will remain in place. That reflects the decisions that states have made at the budgetary and operational level and would minimize disruption for states and beneficiaries. I just want to call attention to the announcement from the Senate Finance Committee yesterday around a policy framework for the future of CHIP, which envisions a 5-year reauthorization and a gradual phase down of the 23 percentage point increase. I think that's a positive step. States welcome that and looking forward to what might be coming out of the House.